everyone. We are absolutely thrilled that our commercial interests you all enough to come and learn about low vision disorders. We're dedicated to educating you all today on some of the most common low vision disorders and the many roles occupational therapists have in their treatment. My name's Danielle Zirkle. Welcome.
Hi, welcome everyone. My name is Nia Bolen-Daniels.
Hello, I'm LaFreniere.
Hello everyone, I'm James Ryan.
Here's our agenda for today. We're going to start with exploring the general structures and functions of the eye, and then we're going to talk a bit more in detail first about macular degeneration, and then glaucoma and cataracts. And then we're going to follow a case study and different videos and simulations for occupational therapy interventions. And then we're going to end it with any questions and a little follow-up. Objectives today are to identify anatomical structures and functions of the eye. And then, as we said earlier, in this order, we're going to start with macular degeneration and then move to glaucoma and cataracts. Within each condition, we're going to be discussing the types, etiology, conditions and prevalences, common signs and symptoms, as well as the occupational therapy interventions and roles. All right, everyone, welcome. Open your eyes and let the world in. Follow me on a journey into the visual system and the eye structures. Our first job at hand is to understand and get inside the eye. So we're going to pretend to be a dust particle floating through space, and we try to get inside the eye by attaching to the cornea. So the cornea is the outer dome of the eye. You can feel it, the shape now if you would like. Go ahead and wash your hands first though and come back. Gently put your index finger over top of your eye. Close your eyelid first though, and then move your eye to the right and to the left. You'll be able to feel that bump. That's the cornea. It helps focus the light that comes into the eye. And there are no blood vessels, but it does receive oxygen from exposure to the air. So nerves would sense us as dust particles, a foreign object, and begin to remove us by blinking excessively and tear production. The eye actually has a really stellar protective layer, and typically light is the only thing that can pass through the eye. So imagine now we're traveling at the speed of light and we get through to the cornea. The dome shape helps focus the light, and then we hit the pupil and the iris. So the iris is the colored part of the eye, and it controls the muscles that can dilate or constrict the pupil. The pupil is the black part of the eye, the opening. Doesn't have any light. That is where the light actually enters to reach to the back of the eye. To pretend to turn down the lights just a little bit, the pupil gets bigger in order to demand for more light to get through so you can see more objects around you. So now we're going to pretend to do that, and so we get through, and now we move to the lens. So the lens focuses the light even more. So what it does is it takes different parts of your visual field and it creates a one focus onto the retina. So it has kind of a bending shape to it, and it actually inverts the images. So at this point, we are not seeing, what we are seeing is upside down, which is pretty cool. So then it has special receptors called in the retina called cones and rods. So cones, there are three different types: red, green, blue, but the eye can detect millions of colors due to the combinations of all of those cones working together. And then the rods, they detect more of the black, white, and gray shades of gray colors. There is they more focus on peripheral visions, and they also help in low light situations such as nighttime. So both of these receptors are extremely sensitive, and they're attached to neurons that then transmit impulses to the optic nerve, and the optic nerve then will transmit electrical impulses to the part of the brain called the visual cortex. The visual cortex then focuses on decoding the upside down image. It also works with other systems to determine familiar objects, determine what to do with the visual information. It's a wide range of abilities and unique visual needs because of the complex interconnections. So while we will be focusing on the most common low vision disorders, it's important to remember that there are vast amounts of visual needs and abilities. Disorders can also be grouped with general symptoms for most people, but we should remember as occupational therapists, each person is unique and possess their own abilities, and same diagnoses may pretty much mean different experiences and ability levels. Education and training situations like these, they're important to have foundational knowledge in order to collaborate with the client effectively, create the most client-centered approach. So our first disorder that we're going to be talking about today is age-related macular degeneration.
So the pathophysiology of AMD is the result of loss of function of the macula, which is the center of the retina. There's two types, wet and dry. Some specific characteristics of dry AMD is progressive atrophy of the retinal pigment epithelial and the photoreceptors in the macula. Some characteristics of the wet AMD is the ingrowth of new blood vessels that break through the neural retina and leak fluid into the lipids and blood. So now going into the etiology, there's a combination of genetic and environmental factors, and there's also some gene presentation that can be contributing factors, the H gene, and some gene variants of B, F, and C2. Also, as mentioned earlier, the environmental factors, which include smoking, obesity, dietary intake, low vitamin A, D, E, zinc, as well as lutein and omega-3 fatty acids. And one of the biggest ones is ultraviolet light exposure.
Okay. So AMD is the leading cause of vision loss worldwide, and it is a severe vision loss in people older than 50 in the US. It's more prevalent in Caucasian and Asian populations. The prevalence increases with age, and dry AMD is more prevalent in Western countries compared to other parts of the world. Some signs and symptoms of wet AMD include permanent and rapid loss of central vision, whereas in dry AMD, vision loss is much slower. Central vision loss is much slower. Peripheral vision pretty much stays intact. There is also some decreases in visual acuity, increased glare sensitivity, and decreased color vision.
So for the role of the OT, the first thing we have to think about is their education. So we need to make sure we're explaining exactly what this diagnosis entails and make sure we're teaching our clients strategies for how to effectively deal with this new diagnosis. And some of the ones specific to macular degeneration were some strategies like eccentric viewing, fixation, and the steady eye strategy, which can aid in that shift from using mainly central vision, as normal people do, to now using primarily peripheral vision because of what's happening due to the diagnosis. Then modification of task and environment, so providing special aids to increase the functionality, including things such as reading glasses to enhance their vision, handheld magnifiers, high contrast items, improving lighting within the home, making sure we're decreasing glare, and then utilizing technological adaptations, things such as larger prints or devices that have a speech function to speak to our clients. And lastly, promoting a pleasurable lifestyle. So making sure we're taking a client-centered approach and providing those necessary assistive devices, technology, and intervention plans that we specifically designed for the needs of that patient and their diagnosis.
Shift some gears to glaucoma.
So the pathophysiology of glaucoma is there's a group of conditions with different causes that result in the damage to the optic nerve head. It's a progressive loss of the ganglion cell layer of the retina, generally caused by increased intraocular pressure. So there's three types: open angle, angle closure, and neovascular. With some characteristics of the angle closure are obstruction by the iris to the flow of the pathway of the aqueous humor. With open angle, it's the damage to the retina caused by the interocular pressure. And then with neovascular, it's a secondary disorder that usually results from other diseases such as diabetes or tumors, causing that blockage to that aqueous humor. So going into the etiology of glaucoma, it's a combination, as heard with AMD, of genetic and environmental factors. Family history does actually increase a person's chances of developing this disease. Gene linkage only accounts for a small percentage of cases, and then other factors contribute, like abnormal blood pressure, cataracts, diabetes, myopia, and hypothyroidism.
So glaucoma is the most common cause of blindness worldwide. Open angle glaucoma is the most common in Western cultures, while angle closure glaucoma is most common in Asian populations. It has a higher prevalence in men and in people of African descent, and it also increases with age. Some signs and symptoms include slow loss of peripheral vision, decreased contrast sensitivity, glare sensitivity, decreased depth perception, difficulty seeing in dim light, and blurry vision.
So for the role of the OT with glaucoma, again, we always want to start with education, making sure they understand this condition, where it's going from here, what to expect, giving them a chance to, if they have questions or concerns, to ask those things, and then teaching them strategies specific to that diagnosis. So for glaucoma, some things such as visual tracking and scanning to help them effectively utilize the remaining function of their vision and hopefully retain it as long as they can. And then modification of task and environment, so providing aids to increase functionality, including things like specialized pill boxes, labeled trays with possible dividers of separate colors to help separate items, make sure they don't get confused, optimizing safe, effective lighting in the home, using things like contrasting colors. And again, technological advances are always around. So some examples would be magnifiers or audio books, audio tapes, just other things to kind of entertain the client that they'd be used to. And then promoting a pleasurable lifestyle. So again, taking that client-centered approach, making sure we're really utilizing everything we have at our disposal and catering it specifically to each patient and their diagnosis.
And now we're going to be talking about cataracts.
So the pathophysiology of cataracts is a crystalline lens of the eye that results in the decreased amount of light reaching the retina. It's made of this broken type of protein that sticks together, and it forms like a sheath that creates an obstruction to the lens. Visual acuity is going to be decreased, and light is often scattered. There is a congenital and age-related type, which is actually the most common. So looking at the etiology, as mentioned before, with this particular disease, there are more environmental factors that include aging, smoking, ocular UVB and radiation exposure, along with drug use, systematic disease, and dietary intake, which increases with age, iodine deficiency, and injuries to the lenses, which is considered a type of trauma.
And cataracts is the third leading cause of blindness in the United States. It is more common in females and in individuals of African descent. It has a higher prevalence in people aged 75 to 85 years old, so it does increase with age. And ultraviolet radiation is expected to rise the incidence of cataracts. Some signs and symptoms include cloudy, blurry, or foggy vision, glare sensitivity, decreased color perception, especially blue hues, decreased visual acuity, and myopia.
And for the role of the OT, so education, always the first thing we start with, making sure they understand the diagnosis and then teaching them some strategies, possibly eliminating some things like smoking or limiting their sun exposure. There's also possible experimental treatments. For example, there are eye drops that contain acetylcarnosine, and it is kind of a possible precursor to if you wanted to try something before just going right into a surgical option. And then if nothing else has worked, cataract surgery would be most appropriate when performance of daily activities and quality of life begin to decrease due to the disorder, and the patient just isn't able to perform their daily functions and enjoy life like they used to, then it might be time for that surgery. Modifications of task and environment, so providing aids that increase functionality, things like prescription glasses, magnifying lenses, anti-glare sunglasses for when they leave the home, increasing lighting in common areas, also removing clutter, cords, rugs, anything that could possibly be a fall hazard is a big importance. We need to make sure that's out of the way for them. And then intentionally organizing their clothes with similar colors on opposite sides, just to make it a little easier for them to get through their day. And lastly, those technological adaptations, so things like larger prints and possible speaking reminder devices. Instead of having them look at something or have an alarm go off and then they'd have to read it, it would just say what they needed to do to kind of eliminate that step. And lastly, just promoting a pleasurable lifestyle. So making sure we're taking a client-centered approach, using all the appropriate devices and intervention plans we have, and catering it specifically to that patient and their diagnosis. So it's the best possible treatment plan for them.
So next we have a case study on a man named John. So please take some time and read it for yourself. This case study is important because it includes many pieces of information that allow us as an occupational therapist to really know who John is as a person and give that client-centered approach. Our job is to assist him into getting back to feeling confident and engaging in activities independently. Here are some interventions that were addressed.
Hey John, how are you today?
Good, how are you?
Oh,
Whoa,
John, hold on.
I hate this stupid carpet. I never see it.
Are you okay? First off.
Yes, I'm okay.
Okay. So is it okay if I take this carpet off the floor?
Yes.
Because I think it'll make it a lot safer for you. Carpets are pesky. They're a fall risk. So is it okay if we just leave that off the floor?
Yes, that's okay. I'm having trouble seeing the knobs on my door.
Okay. So what I can do for that is I can put brightly colored tape all over your cabinets, and it'll cue you to, there's the knob. I can also label these. It'll make it easier finding things. And then also what we can do, because I see you have a lot of spices in here, we can also put these labels on the spices like that. It makes it much easier to see.
Sounds good.
Okay, John, so what else can I help you with today?
I'm having a hard time seeing things on my plate.
Okay, let me take a look at the plates that you have in here. So is this the plate that you normally use?
Yes.
Okay. So I'm going to suggest that you start using darker colored plates. It'll make it a lot easier to see your food. It's a higher contrast.
Okay.
So for example, if we take some keto, which I know is your favorite snack, which one is easier for you to see?
This one.
Okay, and that's due to the higher contrast.
You have learned about 3 common low vision disorders and some OT roles and interventions. Now it's time to experience firsthand how different low vision disorders affect engaging in occupations. Please download one of the 2 free phone apps that simulate some type of vision loss. That's right, you're now the client. Explore different disorders such as glaucoma, cataracts, macular degeneration. There's plenty more as well. Try different techniques as you engage in these activities. Does changing the lighting help? Do you see any barriers or supports you didn't anticipate? What would you address as an OT? We have recorded 2 videos simulating John's vision for those who are unable to download. They will play next as we discuss the interdisciplinary teams and frames of reference. John has an interdisciplinary team consisting of an ophthalmologist, primary care doctor, and us, an OT. We work with the team collaboratively to provide a safe and effective treatment plan. We should know the roles of each member, their treatments given, and if we can provide any support, such as medication management. Throughout treatment, we will need to reevaluate and adjust goals as needed.
When looking at our clients who have low vision disorder, we will use the PEOP model to guide our session in identifying the things that our clients need, as well as their goals, to ensure that the treatment session is beneficial. On the AOTA website, there are practice guidelines and frame of reference specific to many conditions, but there is so very few for low vision disorder. In the future, we hope to see more guidelines and framework related to low vision disorders as therapists become more specialized in this area.
We are open to any questions, comments, concerns, any personalized questions you would like, or any demonstrations we have not provided in this video. Please feel free to email us or call us. Our phone numbers and email are posted above. Thank you so much for coming. I hope that you had a great time.